Good morning, everyone, and thank you for joining us for this workshop. Nice and cosy and interactive, so it can be more workshoppy, not lectury. Could you please come closer to the front for the first part, and then we'll divide back into the tables after the first part. So please do interrupt to discuss things as we go along, so it really is more interactive. So on behalf of the four of us, we welcome you and hope that you take away something really practical, or if you're not in a clinical role, you take away some knowledge that you can use to influence this topic and improve the implementation of pelvic floor muscle training in health services. We might come back to the evaluation at the end, but certainly phones on silent, please. We've already done the handouts. Hopefully you've been able to download them, but we'll put together a slide presentation after that you'll be able to access, so you don't need to take photos of our slides. We'll be able to distribute that via the ICS. So let's make a start. I'm Helena Frawley. Nice to see everybody here. I have no disclosures. Here's our running sheet for the morning, for the 1 hour that we've been allocated. We've condensed this workshop from, I think we've done it in 3 hours before, haven't we? So we've been ruthless in cutting out what we hope are right down to the really essential signposts for you to get an idea of this topic of implementation. So we'll have a couple of presentations that will introduce the concepts that we'll refer to, then we'll spend the most amount of time on the group activity so that you can really apply those concepts and then come back together to discuss. So I'm Helena. Let's start with what it is we're talking about. What is implementation? It's been around for a couple of decades, but it's become much more popular now to talk about implementation of evidence into practice so that we bridge that research clinical practice gap. So implementation is a process. It's quite planned and structured and usually tailored to the context. It always involves identifying the barriers to the thing that you are trying to implement, and so we'll do that this morning. It uses the message itself, so in this case the evidence for pelvic floor muscle training, and it applies it into a context. So that's very important to remember, that it's got to work in that context. Implementation research is the study of that process and using evaluation methods to evaluate how effective the uptake of that evidence was. What should we implement? Well, we should only implement evidence that is quite robust. So evidence that's been gathered through randomised controlled trials, it's been synthesised in a systematic review. That's the kind of evidence we should implement. It's the final stage of testing a hypothesis. So we should not be implementing something that's still down at the theory or the modelling or the preclinical trial stage. Getting from RCT to implementation, though, is not an easy step, and it's not a single step. So we need to go through a couple of processes to get to implementation, because if we don't get to implementation, we don't achieve impact. So if the whole aim of what we're doing in clinical practice and research is to improve the patient's health and health outcome, we need to have an impact at the patient level. So doing the research itself does not change health for a patient. Doesn't matter how good the evidence is, how good the research was, we change nothing until we can implement it. So we do the research, then we have to disseminate the findings, then we hope that people will uptake that finding, then they have to implement it into their practice, and it's got to be delivered to a patient in order to get that end result of impact. So as you can see, it's not a single step, and it's certainly not an easy process, and we'll look at some details around that today. And it takes a very long time. You've probably heard this quote before, that it takes 17 years for research to be integrated into practice. But it's not even all research. It's actually only about 14% of evidence finally makes it after 17 years. So that's a little bit woeful. Hopefully with the strategies we'll look at today, we can improve that statistic. So what is it that we're talking about implementing today? It's pelvic floor muscle training, because that's recommended as first-line management by our society and many others throughout the world. And this is what it looks like. You're very familiar with how do you actually do it in a clinical scenario. So you have a patient, a therapist, and it happens. And there are a lot of opportunities for that to occur in clinical practice, but it doesn't occur everywhere. It's certainly not first-line management everywhere. It's not routine. So what do we know about what's required for it to work? We know that there are certain things that pelvic floor muscle training needs to have and do for it to work according to the evidence. So if we're implementing with fidelity to the evidence, we need to do these ingredients. But we know that this doesn't occur routinely. It's quite erratic and spasmodic and very context dependent. It may be more it may be easier to do it in the private system where people have more autonomy and independent control, but that's not a population-wide approach. It's never going to reach the hard to reach, the vulnerable, and probably those who need it the most. So we really now need to move beyond that patient-clinician interaction and take a whole of health system approach. So that's the third part of our workshop title is health services. So what's the health service? Where does that sit? Well, if you think of the clinician and the patient at the micro level, that's where the evidence has been generated. So we know what works at that level, but that's not how you impact population health. You've then got to consider the meso, which is the social and organisational context of that health service delivery. And of course, that sits within the macro, which is determined by economic, political, policy level, if you like. So we won't change health outcomes for women with incontinence or prolapse if we stay at the micro level. We've got to work much harder to implement beyond that level. Therefore, we need to make sure change occurs at all levels through the health service. But what happens when we try to push evidence through to clinical practice? We get some leakage through the system, or attrition through the pipeline of research to practice. And again, it's not a single step. We get dropouts along the way. So we start with valid level 1 evidence that pelvic floor muscle training should be implemented. Most people are aware of that. Most people accept that that's a good thing to do. But by the time we get down to people actually doing it in a sustainable way to make a difference to women's health, we've dropped down to 25 to 35%. And that's common across all sorts of guidelines, across all sorts of healthcare. So these are 5 guidelines that relate to lifestyle advice for a particular condition. And you can see that there is that attrition at each level through aware, agree, adopt, adhere, where there's this constant drop-off. And when we look across lots of health areas, these group of authors took 29 guidelines across lots of different health, and they found that the average adherence was between 25 to 35%. So we're not alone. We've got the same problems as other health systems. So that's why we need to move it through the whole of the health system. And the rest of our presentation will really focus on that top end, if you like. How do we move it beyond? But because we're more familiar with the patient-clinician interaction, if we start to think about, well, what are the barriers at the micro level and what strategies can we implement there? There are lots of barriers. This is just one example. Who does it? In my context, it might be a pelvic floor physiotherapist who's done extra training. In another area, it will be a different clinician who is the interface in maternity care. It's very context dependent. So what works in one context, according to the evidence, may not be applicable or appropriate or able to be implemented in another context. So we need to start contextualising what happens. When we move up to that next level of the social and organisational context in which it occurs, we get the problem of scale up. So something in research that looks very easy to do, you then recommend that it's done in the health service that you work in, but there isn't sufficient resources to do it. So the active ingredients get diluted. So instead of 6 episodes of care with a physiotherapist, we'll do 4 because that's all we can afford in this health system. And instead of a 30-minute consultation, look, the waiting list is long. We can probably only afford 15 minutes. So you can already see it's being eroded. So it's diluted, it's eroded, and we don't have fidelity anymore. We've lost that real true evidence. And, you know, goodness me, childbearing year, we've got loads of competing priorities. We've got to talk about all sorts of things to do with maternal health and the baby's health. So whose priority is more important? It depends on the agenda of the health service and the clinicians. What's happened in research to look at this? A Chinese group looked at could they implement the evidence? So they gave an education information program to nurses and women. However, this was really knowledge-based. There was no clinical instruction given. That the nurses and the midwives did not observe a correct contraction of the pelvic floor, and there was no supervision of pelvic floor muscle training. So you really can't say that was implementation of evidence. That was application of knowledge. And when we tried to do it in our study to really implement evidence with fidelity to the research, we found enormous barriers. And often these efforts are only sustainable when that researcher or that clinician, that champion, is there. And when that person moves on, it dies out. So we need to start thinking about how do we allocate our resources more effectively. So remember, we've got the competing priorities, we've got contextual differences. Can we use these people in a better way? Can we use one professional perhaps to do the screening? Can we then get that professional to refer to somebody else who's able to deliver the service? Can we get some communication going between those two people? Can we get continuity of care through pregnancy through to the postpartum? Can we get one of the professionals to start talking to the postnatal clinicians, the maternal and child health nurse, the nurse continence advisor? Can we get them talking to the physiotherapist to factor them into their programs? So perhaps with better communication and networking, we can use the very limited resources that we do have in a smarter way. In the health service, I tried to do this implementation research. The midwives didn't know that there was a physiotherapist in the continence clinic who could see pregnant women. She thought it was just for aged care, that a continence clinic would only see aged care. So even within the same hospital, there was a lack of communication between the two groups of providers. So we need champions. That's always really useful if you've got somebody to advocate for you. And when you go up to that top level of the system, the healthcare system, where we often find if it's mandated at the top, we get a top-down approach, and it works because it's part of your pathway of care. Well, I can tell you that's not working in my country. So from the top down, we are not being given consistent, clear messages of how to implement this evidence of pelvic floor muscle training in the childbearing year. This is the most recent government guideline of antenatal care. How to implement pelvic floor muscle exercises is not mentioned once. It's 120 pages, no mention, and there's level 1 evidence. So 120 pages of a lot of other things, but it's not there. This came out last year. This is a government organised report of the evidence, the state of women's health in Australia, and that is to form the government strategy for the next 10 years. Another 100-page document of every condition that affects women's health. The word incontinence not mentioned once. And yet it has a higher prevalence than all of the other conditions they focused on. So we're certainly not getting a top-down approach in Australia. We'll probably need to do a bottoms-up approach for it to work. And I'd just like to refer to the excellent review that Sarah Jean and Rohini have been involved in, that I've joined more recently, and this manuscript is under review. If you were at ICS 2 years ago, you may have heard this presentation. So it's a fabulous review of this particular topic. So that'll be a great resource to use when that's published, talking about the barriers through the whole health system. So to finish on that note, that implementation is difficult, but we've all got an opportunity to do something. So I'll leave it on that note, and Jean will take you through the next part. Thank you.